Buenas noches, me da mucho gusto saludarles y por contar con la atención de todos ustedes deseo manifestar nuestra gratitud a nombre del Consejo Directivo del Colegio de Pediatría de Nuevo León y a la vez brindarles la más cordial de las bienvenidas a esta sesión académica internacional y que estamos transmitiendo en tiempo real desde la sede del Colegio de Pediatría de Nuevo León en Monterrey, Nuevo León, México. Saludamos con mucho afecto a quienes siguen esta transmisión localmente y desde diferentes sitios y ciudades del territorio nacional, así como en las diferentes ciudades de los Estados Unidos de Norteamérica, de Centro y de Sudamérica. Saludamos también con mucho afecto a nuestros amigos y colegas de los colegios de pediatría de todos los estados de la República y que están afiliados a la Confederación Nacional de Pediatría de México, y en especial al doctor Jesús Gerardo Guajardo Treviño, presidente de la CONAPEME, y a la doctora Ana Rosa Sumano, vicepresidente de la misma. En el Colegio de Pediatría de Nuevo León nos interesa mucho mantener nuestro programa de educación médica continua siempre a la vanguardia, con la finalidad de brindar a la comunidad pediátrica y de sus especialidades afines actividades académicas de gran calidad que fomenten los conocimientos en los diferentes ámbitos relacionados con la salud infantil. Por lo que deseo reconocer y agradecer públicamente a todos y cada uno de los integrantes de la mesa directiva que me honro en presidir sus esfuerzos en la planeación, organización y desarrollo de un programa académico con gran calidad clínico-científica. Para la realización de esta sesión académica internacional nos sentimos muy honrados en contar con la colaboración de una prestigiosa organización conocida mundialmente. Es el Children's Hospital of Philadelphia, por lo que deseo agradecer y saludar a Víctor Negrón, quien es el director del Departamento Internacional de Children's Hospital of Philadelphia, todas las atenciones brindadas a nuestro colegio en la facilitación y por la participación en nuestro programa de educación médica continua. Víctor Negrón, mucho gusto, muy agradecidos en que estén participando con nosotros. Es un verdadero honor contar con ustedes como aliados en la organización y en la educación médica continua, en las conferencias que nosotros podemos dar a nuestros socios y a nuestros colegas pediatras. Muchas gracias. ¿Tienes algunas palabras para nuestra audiencia?
Sí, muy buenas noches. Gracias, doctor Luis. Saludos y gracias también al Consejo Directivo del Colegio de Pediatría de Nuevo León, a la doctora Ana Rosas de CONAPEME, al nuevo presidente de CONAPEME, saludos, y a todos aquellos que se están dando participación en esta noche. Es un honor y un placer, en realidad, el que tiene el Hospital de Niños de Filadelfia, el poder compartir en este foro, donde sabemos que altos médicos se dan asistencia en esta noche para escuchar el contenido que queremos compartir y podemos compartir en esta noche. En la realidad, esta amistad a través del doctor Juan Manuel también viene por muchos años, y creo que, como dije antes, es un honor el poder trabajar en conjunto con ustedes. Estamos en toda la disposición en el Hospital de Niños de Filadelfia. En esta noche quiero recalcar, al final de la presentación, el doctor va a poner una página donde hay unos recursos que son gratis para todos accesar. Son protocolos médicos. Hay una aplicación que se llama Open Access, donde están todas las charlas y videos de los médicos de CHOP que se han puesto en conjunto, y creo que es algo que podemos traer al médico latinoamericano y de otros países para que se puedan beneficiar. Sin más preámbulo, nuevamente gracias y los voy a dejar con un video que en realidad cuenta la historia de quiénes somos en CHOP. Muchísimas gracias.
Somos CHOP y no podemos esperar a mostrarles quiénes somos. Somos el primer hospital para niños del país. Ahora, una red de cuidado de la salud con más de 50 ubicaciones que sigue expandiéndose. 3 edificios de investigación de última generación con 1,5 millones de pies cuadrados de espacio. Hemos crecido de 12 camas hace 165 años a casi 600 camas y a ser uno de los mejores hospitales para niños en el mundo. Tenemos un centro de trauma nivel 1. 11 pisos de unidades para pacientes, más de 20 quirófanos, una unidad de parto para bebés con defectos congénitos primera en su clase, una suite de operación y cauterización cardíaca separada, así como lugares para el aprendizaje como nuestro reconocido centro de simulación. Hemos entrenado a generaciones de líderes en el campo de la pediatría. Somos líderes mundiales en medicina, cirugía y ciencia y uno de los principales receptores del financiamiento de los Institutos Nacionales de Salud. En este edificio, pioneros en la terapia CAR-T, enfermedad mitocondrial, tumores cerebrales, hiperinsulinismo y otras enfermedades poco comunes. Aquí se realiza un trabajo de vanguardia en cirugía fetal, genética y genómica y neurología. En nuestro edificio contamos con líderes en determinantes sociales en la salud, informática y epidemiología clínica, autismo, prevención de traumatismos y heridas. Nuestros pacientes vienen de todos los estados y de 115 países. Superar estos desafíos requiere de los mejores y más brillantes expertos. Nos apasiona la pediatría. Nos motiva poder hacer la diferencia en el mundo y en nuestra comunidad. Somos un equipo. Somos CHOP.
Muchas gracias nuevamente, Víctor Negrón, por esta participación en representación de CHOP, una gran institución. Y Víctor Negrón, pues más que un colaborador, es un gran amigo del Colegio de Pediatría de Nuevo León desde hace muchos años. Pues bien, esta noche tenemos la participación con un tema muy importante en el contexto de la oncología pediátrica, y está a cargo de uno de los más importantes líderes en la materia a nivel mundial. Es el doctor Jason Freedman, a quien le expresamos nuestro muy especial agradecimiento, ya que sabemos que es una persona con actividades clínicas, de docencia, de investigación. Le expresamos nuestra gratitud por haber aceptado la invitación para compartirnos sus conocimientos y experiencias en el Colegio de Pediatría de Nuevo León. Voy a tratar de dar un breve resumen curricular del doctor Jason Freedman. El doctor culminó sus estudios de medicina en la Universidad Estatal de Nueva York, en Syracuse, Nueva York. Realizó su internado y residencia en pediatría en Children's Hospital of New York Presbyterian de la Columbia University, en donde fue jefe de residentes de pediatría en ese mismo hospital. Cursó su posgrado en hematología y oncología pediátrica en Children's Hospital of Philadelphia, en Filadelfia, Pensilvania. Está certificado por los consejos de especialidad en hemato-oncología pediátrica y en pediatría. Además, posee una maestría en ciencias en epidemiología clínica por la Universidad de Pensilvania. Se desempeña actualmente como médico tratante y profesor, es director médico de oncología y del programa de trasplante de células madre. Es profesor asistente de pediatría clínica en la Universidad de Pensilvania, Escuela de Medicina Perelman. Y pues esto es un breve resumen. Yo me disculpo ante el doctor Freedman por las omisiones que de veras son involuntarias, porque es muy difícil hacer una condensación de un currículum y una trayectoria tan brillante como la del doctor Jason Freedman. Doctor Freedman, muchas gracias y adelante con su plática.
Thank you very, very much for having me today. I am so excited to be here, and I really enjoyed presenting in person several years ago. Today, we're going to talk about supportive care in pediatric oncology. We are curing more and more children of cancer, but in order to make advances, we also need to make the therapy more tolerable and make the treatments cause less side effects. Today, I want to show you some of that work that we're doing and how we take the best care of these patients. We're going to talk about many of these topics, including nausea, vomiting, nutrition, pain, infection, and transfusion. Nausea and vomiting in pediatric cancer patients is caused by many things. First, chemotherapy, radiation, some of the treatment, sometimes where the tumor is located itself can cause nausea and vomiting, and other medications we give as well. The consequences of nausea and vomiting in these patients are significant. Not only can it cause dehydration, problems with electrolytes, weight loss, but all of this leads to more time in the hospital, potential increase in infections, and also we can't continue their chemotherapy if they're having significant vomiting. There is a specific timeline of nausea and vomiting related to chemotherapy. The first is called acute, and that is any nausea and vomiting occurring within 24 hours of receiving the chemotherapy. Delayed nausea and vomiting occurs after 24 hours, but can persist for up to a week after chemotherapy is given. Breakthrough is the term used to describe nausea or vomiting that happens despite giving a child the proper medicines to prevent chemotherapy-related nausea and vomiting. And perhaps the most challenging of all types of nausea is anticipatory nausea. This is when a child comes to clinic, sees their doctor, or has an anxiety response to just being in clinic. It's a preconditioned response, and up to 25% of patients have this. It is very difficult to control this kind of nausea and vomiting. And all of this is to say that not all nausea or vomiting is the same. And when you see a patient, we need to tease out exactly why they're having it. If you remember back from medical school, there are many types of inputs to the chemo trigger zone in the brain. It's mainly in the fourth ventricle and the medulla. We have the histaminergic receptors. We have dopaminergic receptors. We have multiple serotonergic receptors. And when thinking about preventing or treating nausea and vomiting in these patients, we want to use medications that hit multiple different targets. What do we think about when trying to find a medicine to prevent nausea and vomiting in these children? We have to think about how strong or how nauseating is the chemotherapy that the patients will be getting. Is it something they're getting by mouth? Is it something they're getting by the IV? We also know that certain patient factors play into whether they're going to have a difficult time with nausea and vomiting. Patients who are younger or at low age or high age tend to do worse than those in the middle. Patients with tumors in the brain or the abdomen also tend to have more nausea. And people who are alcohol naive or non-drinkers, which hopefully most of our patients are, also have a lot more nausea during chemotherapy. I want to bring your attention to brand new nausea and vomiting guidelines. CINV refers to chemotherapy-induced nausea and vomiting. The Pediatric Oncology Group of Ontario, in conjunction with the Children's Oncology Group, put together brand new guidelines to help all of us be better in preventing nausea and vomiting in pediatric cancer patients. I'm going to walk you through this guideline, which we at CHOP built into our system. Again, the website is here for you, chop.edu/pathways, and I'll show this again later. If we look at this pathway up close, you can see that to decide how to prevent nausea and vomiting in a patient, you want to start by determining the chemotherapy emetogenic potential of the chemo. This means, on average, how many patients will vomit out of 100 if given that chemotherapy agent. And we break them into categories. Those agents that don't cause much vomiting are minimal. Those agents that cause low level or LEC, those that cause moderate or 30+% of patients would vomit is MEC, and those chemotherapies where 90% of children would vomit if not given medication to prevent it are called HEC, or highly emetogenic chemotherapy. You can see here, and this is published on our pathway, the agents that we associate with each category. So if treating a patient with vincristine or vinblastine, we often don't think of those as very nauseating drugs. A little bit more would be doxorubicin, gemcitabine, and mitoxantrone. Some of the more common drugs that you're used to are etoposide, ifosfamide, imatinib, and methotrexate. All of those fall in this category where without proper medication, 30 to 90% of the children would experience significant nausea and vomiting. And finally, the agents we use for many solid tumors, transplant, and leukemias are combination regimens where 90% of the children would vomit. This really includes cyclophosphamide and high-dose doxorubicin. Once we have decided what the emetogenicity or how nauseating the chemo will be, we then group them based on those categories and can determine how to best prevent that nausea and vomiting from happening. I will tell you that it's all based on what the patient can and cannot have. As you see here, there are contraindications, or in specific patients where they're not allowed to have certain drugs that are very good to prevent nausea and vomiting. And I'll go through those in a minute. But if there are no contraindications, you would give a patient the drugs listed here. If there are, you walk through this pathway to tell you which of the regimens the patient is able to have. The most important drugs and the advancements in treating cancer came when the discovery of the serotonergic antagonist, or the 5-HT3 antagonist, came online. These are Zofran or Velcor, Kytril, or Aloxi. These are antagonists to serotonin, which are excellent drugs at blocking nausea and vomiting. These are the starting point for all of the regimens. In children who are very young or have prolonged QTCs, we cannot use these drugs. Dexamethasone is an excellent anti-nausea drug. However, there are certain patient populations in which we would not want to use this. Many leukemia lymphoma patients are already getting steroid as part of their treatment. Patients getting immunotherapy or CAR T cells would not want to give them steroids because steroids could directly injure or dampen that treatment. It would kill the T cells. Patients who have other issues that steroids could worsen, like low bone density, glycemic problems, or patients who are just finishing a bone marrow transplant at a high risk of infection, we often avoid dexamethasone. Amend or aprepitant is an NK1 antagonist, neurokinin 1. It has been a game changer when it comes to treating nausea and vomiting. And the only significant things are that if you're less than 6 months, you can't get it. And if you're getting ifosfamide, there are significant drug-drug interactions. As you can see here, in experienced hands of a clinical pharmacist, we are able to provide these drugs in combination and bring nausea and vomiting under significant control in these patients. When patients are having that anticipatory nausea vomiting I mentioned before, the anxiety-produced nausea, benzodiazepines, lorazepam, Ativan, midazolam, those are the kind of drugs that work very well for this. When patients are having other breakthroughs or nausea and vomiting despite the upfront drugs, we consider other newer things like giving them olanzapine. This is an antipsychotic that has significant anti-nausea properties. And when used properly in the right doses, it is excellent at controlling refractory nausea and vomiting. If a patient was started on a regimen in the low moderate category for nausea, you would move them up to either moderate or high. You always move the patient on the next cycle of chemo to the higher level of nausea drug. Other things to consider are acupressure, patches that can help with nausea and vomiting that go on the neck, dronabinol or marinol, and again, steroids if you haven't used them already. I want to also draw your attention to other tools that can help you decide how and what drugs or therapies to give a patient whose nausea and vomiting is significant burden to them. The Children's Oncology Group and the website listed here, childrensoncologygroup.org, there is a supportive care section that I've highlighted below. You don't need to be a member to access these resources. When you click this button, you will see implementation tools on the left. We have designed several tools to help you walk through nausea and vomiting risk assessment to decide which drugs a patient should get based on chemotherapy, as well as for patients with significant challenges in managing their nausea and vomiting, a tool called the Rapid Assessment Tool to help you determine other strategies to help them. Again, we won't walk through it all here, but you can see that this will walk you through how to choose the therapies. Also here, the Rapid Assessment Tool will suggest other causes of nausea and vomiting to make sure we're not missing things like post-operative nausea, reflux, significant abdominal pain, and also calls your attention to using adjunct therapies like psychosocial involvement or psychology involvement. We're going to move on to nutritional support now. Nutrition is critical for patients getting chemotherapy and patients with cancer. We know from a lot of research that patients who are at either end of the weight spectrum, either too heavy or too skinny, will have worse outcomes than patients who are in the middle. Malnutrition is very prevalent in oncology patients. It can lead to poor absorption, poor vitamin, decreased intake, and when that happens and malnutrition is the result, you can end up with more infections, longer hospitalizations, and cure rates that are different if you were in a healthier rate zone. When nutritional supplementation is required, we try to do things by mouth. If patients are able to take a supplement, formula, Pedialyte, Pediasure, by mouth, that is certainly the best option. We say use it or lose it. If the gut is working, we like to use it. The second line would be putting a nasogastric tube in place, especially if they're having significant vomiting. Contrary to what many parents will think, an NG tube is going to help promote promotility, moving things forward in the GI tract, and can actually significantly reduce nausea as well. So if the patient doesn't want to take the food or formula by mouth, we can put a tube in the nasogastric area and bypass the mouth. And this is very successful in many children. The final line is using TPN or total parenteral nutrition. This is, of course, nutrition through the vein or through the port, central access. We don't like to use it for long periods of time, but it certainly is helpful to keep a patient rehabilitated nutritionally. And the final is through parenteral nutrition. through a central line. If the patient is eating, considering appetite stimulants would be appropriate. Let's move on to pain management. Please remember that cancer-related pain is not just because of cancer. It could be where the tumor is located. It could be because of a procedure we did, like a spinal tap or a surgery to remove a tumor. We may have caused neuropathy because of where the tumor is located or the surgery to treat it, or medication we gave, like vincristine, may have caused it. Finally, some of the treatment itself, such as avascular necrosis or side effects of radiation, chemotherapy, or skin burn, may also cause pain. So it's very important when assessing pain in children with cancer to take a very strong history. Is it acute or chronic? Did it just start or has it been recurrent? What type of pain is the child having? Is it somatic? Is it muscular? Is it neuropathic? Where is the child in their therapy? Did they just have procedures? Did they just have surgery? Or are they off therapy? And this is something very different than related to their treatment. You want to do a physical exam for all the sources of pain. You want to ask the parent, what is their assessment of the child's pain, if applicable? And finally, remembering that pain in children is not all equal. Pain can be a sign of other comorbid symptoms. They could have fear or anxiety, depression. They could also have issues with their sleep, and it could really be interfering with their activities of daily life. So it is critical to understand, as sleep disturbances, depression are very underreported in our population. When treating pain that's determined to be organic and related to something that somatic that needs treatment, there's a WHO approach, which is a two-step strategy. The first is for mild pain, where we try acetaminophen or paracetamol. We cannot use anti-inflammatories like Motrin or ibuprofen because of their effects on platelets in patients who already have low platelets. The second step is really to move to a moderate to severe drug, which would be opioids. We try to do oral drugs before IV, but if we need to do IV, that is perfectly acceptable. And again, dosing at the right interval, which usually is a regularly scheduled dose. The right dose is the dose that works for that particular patient. And many times we order the doses as needed. Sometimes that means the patient doesn't actually get the drug. And we have to be careful that with cancer-related pain, we are giving the drug on time and in a regularly scheduled fashion. We may also need to advance from every 3 or 4 hour dosing to a patient-controlled analgesia, which is where they get a continuous amount of medication throughout, and then a button to add more pain meds when they need it. Also remember that we really should combine the medication treatment with cognitive behavioral therapy, physical therapy, and psychological therapy, because often these issues are intertwined. There are special considerations when it comes to pain. Again, not all pain requires opioids. Sometimes for neuropathy, GABA drugs are very helpful. Gabapentin or gabapentin or Lyrica or pregabalin are very helpful. Sometimes we use tricyclic antidepressants or anticonvulsants, but again, those are falling out of favor. Remember that pain medication may need to be tapered and should not abruptly be discontinued. I've already mentioned this and alluded to this, but really think about what else can we do to support these patients. If a child is going for procedures, can we get a child life specialist or their parent to be a distraction? If they're going to get their needle changed on their port, can we put cream on that will numb the skin? If it's after a procedure, is there art therapy or music therapy or something that the child enjoys doing that we can engage them and distract them? Can we do physical therapy? You always want to, as good clinicians, anticipate the side effects of any of these therapies, including opioids. There are many negative side effects as well, such as itching, sleepiness, respiratory depression, and those are rare when used in experienced hands. But the one side effect that patients will never become tolerized to is constipation related to opioids. So you need to prepare for that, and you need to think about a strong bowel regimen like Senna, Colase, things to keep it mushy and to help the stool come out to prevent the patient from having yet another symptom. Moving on to one of the most important topics related to caring for a cancer patient is infection. Up to 15 to 16% of children can die during the initial therapy for leukemia if they are not properly treated or recognized to have an infection. 20% of patients will get a bloodstream infection, and 30% may get a hospital-acquired infection. These are staggering numbers and speak to the reasons why preventing and treating infections is critical. When you are assessing the risk of a patient with cancer, you need to think about certain things. What type of cancer do they have? Those going through HSCT or transplant and those with leukemia have a much higher risk of infection. How long and how deep is their neutrophil count going to be low? Is their ANC 0 or is it normal? Did they get a growth factor that helps their bone marrow in a couple more days? Or do we expect their blood counts to be down for another week to 3 weeks? Patients with immune disorders or chemotherapy-caused T-cell dysfunction are at a higher risk of infection as well. And the sheer presence of having a central venous catheter increases the risk of an infection significantly. As you can see here from one study, there were about 2 line infections per 1,000 catheter days, and all of our patients have catheters. Just to refresh your memory, there are several kinds of central lines. A PICC line or a peripherally inserted central catheter is like a long IV, but it goes into deep central veins. A Broviac comes out of the chest, but also goes to the deep central veins. And a port, the most common, is tunneled under the skin, accessed with a small needle, but again, enters into the central vein. These allow for significant things like transfusions and fluids and chemotherapy, but come with a cost, a high risk of infection at the site of the line, infection inside the line, clots, sometimes occlusion, and sometimes they need to be removed. When you are examining a patient who has fever, you want to remember that fever in a cancer patient is considered an emergency until proven otherwise. Take very good history, asking questions of the family and the chart. When was the last chemotherapy? Did they get any recent blood transfusions that could account for some of these signs and symptoms? What kind of line do they have? Look in their mouth, look in their gums, look for lesions. Remember, patients who have been on steroids or have gotten chemotherapy or whose blood counts are low may not have the same signs and symptoms of an infection that patients with normal blood counts have. Look at their line, look at their site. Is it red? Is it tender? Look at their skin very carefully for any lesions that look odd. A small red dot that's not a petechiae. A small purple dot that looks weird that's not a bruise. These can be signs of deep infection like mold. Look around the perianum, look for tears. Feel the belly. Is the spleen big? The liver big? All of these may help you when the signs and symptoms of a true infection are absent. When a patient has a fever, we obviously do a blood count. We want to do blood cultures, and we culture each of the lumens of the central catheter. Whether or not we draw cultures from the peripheral veins is controversial. At CHOP, we do not, but at many institutions, they do that also. If the catheter is draining purulent material, you would want to send a culture and a gram stain of that. If it is a very young child with urinary symptoms, you might consider sending a urine culture. But remember, in a neutropenic patient, we don't want to do any catheterization. If a child is experiencing cough or respiratory problems, you can consider a chest X-ray and viral testing, especially in COVID time, but it's not essential to do a chest X-ray until symptoms progress. There are many accepted standards for treating febrile neutropenia. That is fever with low neutrophil count. The most important thing to remember is that gram-negative rods are the most common and can be the most deadly. Other high-risk organisms include strep viridans, so you want coverage for all of these things. The most commonly accepted are the fourth-generation cephalosporins like cefepime. There are Zosyn is also acceptable, and other combinations, including gentamicin and other things, are accepted, and your institutions may do something different, and that is totally acceptable. What we want to agree on is that we would usually continue the antibiotics until those blood counts have started to rise back to normal. But I will tell you that that is also controversial and not the accepted standard. You may want to broaden their antibiotic coverage for specific things. We may add vancomycin or more gram-positive coverage if the patient has sepsis or is clinically unwell, or if they had a recent infection where vanco was the treatment. I do want to call your attention to the fact that VRE-positive patients where vancomycin-resistant enterococcus in a patient does not mean you can't use vanco to treat that patient. If they are clinically unstable, you would choose something different, but otherwise you can use vancomycin. If you're concerned about the belly or the abdomen, you would want to add coverage for gut bacteria. If they are worsening, you're going to broaden your antibiotics accordingly. One thing to remember is that many patients treated for leukemia can be adrenally insufficient. And if they're very hypotensive, you need to think about, do they have a lot of prior steroid exposure, and they may need stress dose hydrocortisone. However, patients getting immunotherapy, as I alluded to before, where you don't want to hurt those special T cells, you would avoid steroids and speak to an oncology specialist. I will let you know that, again, on our clinical pathways at CHOP, which are free and accessible to all of you, how we treat fever and how we assess patients is all here on the pathway. We invite you to look at it, and I feel free to email me with any questions. I'll provide that at the end. Because we're short on time, I'm going to go through this quickly, but I just want to let you know that there are new guidelines that not every single patient with cancer has to even be admitted for a fever. It depends on the type of line, where they are in their therapy, and if they meet several what we call low risk criteria, then they can go home as long as our clinic and our nursing team calls the family every day, provides them an antibiotic that they take at home by mouth, and we can assure follow-up that is proper. This is a new emerging field, but in the right patients, this provides opportunity to decrease those patients in the hospital, less infections in the hospital, and have a family at home. Bacteria are not the only thing that we think about. We also think about respiratory infections, flu, paraflu, in the young children, RSV, and especially now, COVID-19. Viral infections account for 44% of all fevers in oncology patients. And remember, because they have an immunodeficiency as part of their treatment, they have prolonged viral exposure, prolonged clearance of the virus, and it takes longer to get better. More children with cancer who have a virus will end up lower respiratory tract disease than patients without cancer. And there's pretty high mortality for viruses in children with cancer, close to 7 to 10%. Herpes viruses are other things we will see and encounter even in primary care. Patients whose T cell function is not perfect. You'll see reactivation of shingles. You may see primary herpes simplex, and most of these are treated with acyclovir. There are patients, if the right window between 4 to 10 days of exposure, they can get an immune globulin that can treat VZV, but it's not always available. I show you this chart to highlight the other viral infections we don't have time to talk about. There are various therapies, but the bottom summary is the most important. There are very few effective treatments for viruses, and viruses cause significant problems to our patients, and we need to try to prevent them as much as possible. And many times, this entails very careful isolation of our patients, who is allowed to visit, screening the parents and the caregivers to make sure they are not bringing diseases into the hospital. Again, we do provide vaccines to our patients to prevent them from getting viruses. We do not give live viruses like oral polio or the rotavirus vaccine, and anything like MMR has to wait several years after treatment. We do give the flu vaccine. We do treat or preventively treat for RSV with palivizumab in the right patients. And now with COVID-19, we are advocating for the 12 age group up to get the vaccine. Another type of very severe infection that happens in those getting a transplant or leukemia in general are invasive fungal infections. They can cause significant mortality, but again, it's the similar patients who are at risk for infections in general, long duration neutropenia, prior history of steroids, long antibiotic courses, and those on TPN as well, or parenteral nutrition. As you can see here, things may look like a benign little red dot, but these should catch your attention in a patient with cancer that this is not just a red dot, and clearly this is not a normal finding. Many of these things need to be debrided in the operating room and removed surgically. As I mentioned before, patients who have low neutrophil counts may not show the classic sign of an infection in their body or on a scan. This is a 16-year-old boy with AML who, when their ANC was 0, had what looked like pneumonia. When their ANC was over 1,000, you could see the classic halo sign of an aspergillus infection. So neutrophil counts definitely help in the diagnosis. I just want to call your attention to the population of patients who are post a transplant. We always focus a lot on this yellow line, which is the neutrophil count, and it goes down and comes up relatively quickly. And that's what happens post-chemotherapy as well. But remember, there are other parts of the immune system, like B cells, T cells, plasma cells, that also need to recover. And they take time from weeks to months post the transplant, about 6 to 8 months before the B and T cells are functioning and communicating. So just because neutrophils are back does not mean the patient's immune system is perfectly back to normal. And this is very important to relay that message to families. I want to end with a short topic on transfusions because this comes up a lot. When we need to transfuse our patients may vary by center. In general, all of the blood products need to be irradiated and leukoreduced. Leukoreduction, or the removal of white blood cells from the product, tend to make it CMV negative or CMV safe, so that we do not transmit CMV to these patients in whom it could be deadly. Irradiation removes any antigens or things that could lead to transfusion-associated graft versus host disease. In general, when giving red blood cell transfusions, we do so if the patient's hemoglobin has fallen less than 7 or they're symptomatic. If they're going for a procedure or they need anesthesia, we often keep their hemoglobins higher, closer to 9 to 10. Platelets are a little more complicated. In general, we will let a patient's platelet count go to 10,000 or less before transfusion, or if they're bleeding or have symptoms, we transfuse them regardless. Bone marrow transplant patients or any brain tumor patient with any residual tumor, we keep higher, closer to 20,000. If you're going to do a spinal tap, we make sure that the platelet count is at least 30,000. And finally, significant surgery, neurosurgery, or other procedures, we want the platelet count at least 50,000. These are guidelines, and again, may be center specific. There are special situations you want to think about when you are doing transfusions or going to do procedures. If any patient has a history of a clot and is on anticoagulation like Lovenox or heparin, you want to keep that platelet count over 50,000 at all times. If a patient is presenting with a new diagnosis like acute promyelocytic leukemia, or they're in DIC, you want to make sure that you fix other elements of the coagulation cascade. You want to provide them with fresh frozen plasma or cryoprecipitate, which is great at fixing fibrinogen, and sometimes vitamin K is necessary. It's not just about the platelets. And finally, remember that patients who come to your clinic or show up in the emergency room with a new diagnosis and a very high white count may have risk for something called hyperviscosity syndrome. This is due to vascular sludging or very thick blood that can cause strokes, pulmonary complications, or other issues in the body. Transfusing these patients rapidly can increase the risk for those situations. Therefore, you transfuse these patients in very small aliquots, and you would want to discuss that with the ICU team and oncology very carefully. Because so many of us work in different settings, I thought it was important to talk about various topics, including infection, which we all see, how to treat nausea, vomiting, and pain, and transfusions. Take these concepts with you, take them to your clinic, recognize some of these things when you see them, even if you don't specialize in oncology. You are going to come across children who have all of these issues. So it's very important to be an astute clinician, ask the right questions of the family and the patient to get the history, because you may be missing something, because cancer can mask a lot of signs and symptoms. My email is right here, friedmanj@chop.edu. I am happy to have emails from you and questions and things that I can help you with. It has been an absolute pleasure to present to you tonight. I'm sorry that we had technical difficulties, and I certainly look forward to being in person with you again in Mexico in the future. I want to also share with you that we have several websites. I mentioned the clinical pathway website, where you can go on and get pathways for free, how we would treat not just cancer or oncologic diseases, but emergency diseases, general pediatric diseases, fever. It's the Children's Hospital of Philadelphia, evidence-based pathways to treating a multitude of diseases. We invite you to log on and take a look. They're all free and very easily accessible. Finally, there's another website listed in green where you can get online free, mobile-friendly pediatric topic lectures like this and resources like this to help you in your practice and take care of patients as best as we all can together as a team. Thank you so much, and I really look forward to, if anybody has any questions, I'm happy to take them at this time.
Muchas gracias, doctor Freedman. Ha sido una plática muy interesante, sobre todo porque nos ha indicado sobre los cuidados del paciente oncológico en vías de, o con el objetivo de mejorar o de mantener el estado óptimo de la salud del paciente que va a recibir tratamiento oncológico. Vamos a dar paso a las preguntas. Por aquí tenemos ya algunas preguntas. El doctor Jaime, de la doctora Janet Montes, dice, ¿podemos usar esteroides en leucemia para la náusea después de inducción de remisión?
So there are certain times when it is appropriate or could be used, but in general, because steroids will be part of the leukemia treatment for many months, up to 2 to 3 years, we generally avoid using steroids as well for nausea and vomiting. So we would choose other drugs and not use steroids. If it's AML, not ALL, AML, a shorter treatment, does not use steroids in the treatment, then it would be fine to use steroids. But again, you have to balance the risk of infection, which is high, with the use of steroids. So it has to be done in an appropriate patient. In our practice, steroids are very good for nausea and vomiting in patients with solid tumors, brain tumors, bone tumors, and soft tissue tumors. That's where I would use it.
Muy bien. Doctor Freedman, pues tenemos un sinfín de felicitaciones y agradecimientos por su plática tan brillante. Desean expresarle sus agradecimientos desde diferentes ciudades del país y pues nosotros como Colegio de Pediatría de Nuevo León deseamos expresarle nuestra gratitud por participar con nuestro programa de educación médica continua. Sabemos, doctor Freedman, que es usted una persona muy ocupada, es autor y coautor de múltiples artículos publicados en revistas de alto impacto, revistas líderes, como lo es Pediatrics y como lo es Pediatrics Blood and Cancer. Además, él es revisor de manuscritos, pertenece a comités editoriales de diferentes revistas como British Medical Journal y de muchas otras revistas líderes en la publicación de hemato y oncología pediátrica. Doctor Freedman, muchas gracias. Le tenemos nosotros un reconocimiento y un diploma que le haremos llegar lo más pronto posible hasta su oficina en The Children's Hospital of Philadelphia. Muchas gracias, doctor Freedman. Muchas gracias a todos. Nuevamente, muchas gracias, Víctor Negrón, por todas las facilidades que nos brindas al Colegio de Pediatría de Nuevo León. Muchas gracias y les recordamos que nuestro Congreso Internacional de septiembre, estén muy al pendientes de nuestras redes sociales porque tenemos muy buenas noticias para todos ustedes. Buenas noches.